We're here today to have a very important discussion about the issues in healthcare facing our business community. And really there are three problems that candidly have been around for generations, but really the last 25 years, and getting worse, not better. And that is access to healthcare, the cost of healthcare, and the quality or value that we get for what we're paying. And business has borne the brunt of a lot of those increases in healthcare cost, and justifiably, they're asking the question, what are we getting in terms of value for this additional amount of money? So that's really the problem statement that we're here to address, not so much to do a deep dive into the drivers of that problem, but really to talk in this complex, rapidly changing healthcare environment. How do all of us in healthcare, the business community, payers, providers, others, how do we come together and come up with practical, real solutions that are going to make a difference?
When you look at business costs, personnel costs, benefits are the number 2 biggest costs for a business. And Louisiana is one of the worst in the nation when it comes to these business costs. And so for us here in Louisiana, this is an issue not just of doing the right thing for our employees, but of also ensuring that Louisiana continues to be a great place to do business. It's an existential issue for economic development. So with that, I want to thank all of you for being here today with us. I want to thank Blue Cross Blue Shield for being an outstanding partner here in Louisiana for over 75 years, a great partner with G&O Inc. for many, many years. And also thank this great hotel, the Grand Hyatt, for being such a wonderful place for us to come post-Katrina.
What I'd like to do this morning is really set the table for the discussions that you're going to have. Michael mentioned that I've been outside of clinical practice, sort of on the management side of healthcare, for over 25 years. And 25 years when I stepped into that role, we were worried really about 3 things in healthcare. We were worried about access, cost, and quality. And I'm pleased to say that 25 years later, even with the Affordable Care Act, we're worried about access, cost, and quality. But I think it's become more of an acute problem over the last 25 years. Rising healthcare costs in particular are becoming a problem, not just because of the economic development issues that Michael mentioned. I'll talk about those in a little more detail. But basically, for the average person, healthcare is becoming unaffordable. Now, I'll just give you one statistics. When the Affordable Care Act was passed, McKinsey, a consulting firm, did a study in the first year after the Affordable Care Act and basically asked the question, if you were above the subsidy level, which at that time was about 400% of the federal poverty level, and for those of you that don't know that math, that's a family income of just shy of $100,000 for a family of 4. So if you had to pay out of pocket, and this is before the rise in healthcare premiums that have happened with the Affordable Care Act. So when it started, if you had to pay out of pocket for your family of 4, what do you think you had to pay as a percentage of your gross income, not net income, but gross income for healthcare? 33%. And it's gotten worse. The reason that that's a problem is, let's just talk about access. Access to health care is not just access to health insurance. We still lag most of the rest of the world on access to health insurance, but even for people that have health insurance, people say that health care costs are preventing them from going to see the doctor or getting the care they need, even when they have insurance. More so than any other developed country in the world. In fact, if you want to, for those of you that have access to the New York Times, there was an interesting article this morning that talked about access. And I'll just highlight a few of those points. It's not just the financing and health insurance, it's actually the delivery system. And so we put more people in with expanding access for the Affordable Care Act, but there actually isn't always a place for them to go. So compared to other developed countries, Europe, et cetera, by the way, we're slightly better than Canada on these measures, but that shouldn't give us a reason to cheer. It is harder for the American public to see a physician after hours than any other developed country in the world, or on weekends. And it's also harder by a long shot to get care within 1 to 2 days of saying that you need it, the lag there. And one of the main drivers of that is a lack of good primary care infrastructure. Real numbers. We have half as many primary care physicians as Sweden, which is the next lowest country, and 1/5, 20% of the number of primary care physicians in European countries like France. So the delivery system to get access here is not there. So access remains, not just from a financing standpoint, but delivery system standpoint, a real problem. We've talked about the cost issue. You know, in the quality side, we spend almost twice as much per capita as most other developed countries. And if you look at life expectancy, infant mortality, other sort of population-based measures of health, we're ranked just above Slovenia, somewhere around 50th in the world. So we pay a lot, but we're not getting a lot. You know, the public gets this. In 1995, when Harris and other polling companies said to the public, what's your number one concern? The public basically said their number one healthcare concern was cancer, followed by AIDS and a number of conditions. Today, by a large margin, when you poll the public, the first problem that they see is healthcare costs. The second problem they see is access, and then obesity and cancer come in third or fourth. So the country has shifted their healthcare concerns from conditions and diseases to financing and access. They understand this. And that's because the out-of-pocket costs for healthcare for the American public have risen more than anything else, and they are crowding out what the public can spend on other aspects of their lives. In Louisiana, we have our own particular challenges. I think, as many of you know, we now have taken the place of Mississippi as being ranked 50th in the country in overall health status, largely because of chronic conditions and just, you know, poor, candidly, lifestyle habits that lead to those chronic conditions. From a cost standpoint, the Institute of Medicine did a study, and we're near the top of this list. 6 of the 10 most expensive places to get care in the United States are in Louisiana, including Metairie, Baton Rouge, and Lafayette. And when Medicare did their benchmarking on a per capita basis, we also made the top 10 list, with Monroe, Alexandria, and Shreveport being among the most expensive places to get care. So again, if you look at that US versus world problem, I think within Louisiana, even within the United States, we've got that same problem, which is we're spending more and we rank 50th. So we really have to do more to change the way healthcare is delivered, not just to improve the health status of our population, but candidly to do something about that inequality of cost and quality, the value problem. So just think about that now. If you're an employer and you're talking to Michael and he's trying to convince you to come to Louisiana to put your business here in one of those cities that I just mentioned, and I'll give you, these are real numbers. If you looked at Phoenix or some places in other places in the Southwest, and you can spend 35% less per capita on healthcare costs, and it's your second largest expense, where are you going to put your business? So it is an economic development problem that I think we collectively need to figure out. What you're going to hear today is not just sessions about the nature of the problem. What we'd like you to engage in these breakout sessions is, what are we doing about it? And what we would say is that part of the reason I think we have this problem as a country, and candidly part of the reason we have this problem in Louisiana, is the system's working perfectly given the way that it's designed. We have a reimbursement system that rewards physicians and hospitals for doing more, not for doing better. And we're practicing it well. So we're doing more and costs are going up, but we're not paying for value and quality, we're paying for volume. We've got to change that. We need to increase the amount of information that all of us, as consumers of healthcare, have about the cost, quality, and value of services that we get, so that we can engage in productive discussions with our physicians and candidly with each other. And if you talk to physicians, and you're going to hear from David Carmouche from Oxford, the breakout sessions on the panel session, what you'll say is they'll say, we can do a certain amount, but we really need to engage the patient, the member, to take accountability for their own health care. So how do we do that? How do we get people engaged to take charge of their own health care? Because candidly, those of us that are on the payer side and even on the provider side, without engaging people on individual responsibility, we're not going to get that change. So what I also hope you come away with today is a sense that these problems are so large and so important that none of us can do this individually. It's really going to take a fundamental different type of collaboration among all of us that have a stake in healthcare to make these changes. And the reason I say that is for those of you who may be students of change, people don't like to change. Maybe 10% of people really like change. 10% probably never will. The other 80% need a lot of help. They'll eventually get there. But it's very hard for them to change because they see the problems with letting go of the past, and they don't necessarily the benefits of embracing the future. So collectively, we need to work together to do something different. You're going to hear today about how we're doing that in pharmacy, about how we're working with our employer customers, how we're working with the delivery system, again, an example of Oxner, and what we can do. And I think these are all things to build on. And when we get to the panel session at the end of the day, I hope that you will have come up with some good questions, some good ideas, and that we can close out this morning with a productive dialogue about a pathway to a better future for healthcare, not just in our state, but in the country. So I hope this day is of value. Thank you for coming today, and I will now turn it back over to Michael for some additional comments and to prep us for the breakout sessions.
Great. Thank you, doctor, for that diagnosis. I guess first you got to admit you have a problem, right? So thank you for that. What I'm going to do just in about 5 minutes is just pull us back a little bit to the macro of the state of industry, to talk about the region, and then kind of pull it back to this forum, and then talk about the breakout sessions. You know, when you look about the state of industry in America today, there are clearly a number of challenges. Productivity is declining. Some of our most innovative companies seem to be getting better at share buybacks than at innovation. They're hoarding their cash. You've got, I think most worrying, a national political class that is embracing protectionism and is eschewing trade. And we just know over time that a fortress economy is not a strong economy. And in fact, if you look at what's going on globally and nationally and even at the state level, to be honest, I actually am feeling awfully good about what's happening here in Greater New Orleans. In fact, I think I can objectively say that at this moment, on this day, I think that the New Orleans economy is kind of the model for the rest of the country and the world. I don't believe I ever thought I would say that, but I think it. So for all of you that are politely giggling, let me just give you as kind of a case study the recent example of what happened with British Airways. Last week, for those of you that might not have heard or might not be anywhere on the internet, British Airways announced that starting this March, you're going to be able to get on a plane at 9 o'clock at night in New Orleans, a Dreamliner, sleep in a climate-controlled environment, and wake up in London the next day. This is a total game changer for Louisiana. I'm so proud of us. But the way that we got there is really interesting. We had great fundamentals. Our underlying numbers were there. We're already sending 435 people a day over to Western Europe, but typically through a place like Atlanta or Houston. And so they recognized that they could go and they could grab that traffic. We're number one in the country for growth in international tourists, 37% increase. So our fundamentals are doing really well. The second thing is that we've got an overall narrative here that I think we have to recognize is perhaps unprecedented in modern American history. And that is that we haven't just come back from the greatest man-made disaster in modern American history. We actually have come back much better than before. There are things that are going on in this economy that would have been thought impossible before Hurricane Katrina, let alone after it. We're number one in the South in economic development wins. We're number one in the nation for young people moving in, choosing New Orleans as a place where they want to live. We're number two in the nation in growth of knowledge industries. And this is all this kind of post-Katrina phenomenon. I guess to use a bad medical analogy, it's kind of like a friend or a person who has a morbid bad lifestyle. They have a mild heart attack. It doesn't kill them. And now they're doing CrossFit and Zumba and they're really annoying. That's kind of what we are now. You know, we're Zumba Nation here in New Orleans. And that's an incredible narrative. And then the third part is teamwork. Making this British Airways flight happen was a result of over 4 years of work with us at G&O Inc., with the CVB, with the Aviation Board, with the airport, with Mayor Landrieu, with the folks from Jefferson, with the governor, with the lieutenant governor, with over 100 business leaders, including Blue Cross, from Lafayette to Pensacola. We all came together to make this case work. So the teamwork also happened. So the numbers, the narrative, and the teamwork, that's why we're winning. So then I say, looking forward, you know, how do we keep this momentum up? How do we ensure that now that our airport, which has Panama, Frankfurt, and London, how do we continue growing? How do we continue to be one of the best places to live and work in the country? And then pulling it back, how do we do it as a nation? And to me, there's one thing that is most important. And I'm saying this as a former business owner, and that is stability. As a business owner, you're only going to invest if you can count on what your future costs are going to look like with some certainty. And you've got to have a sense that they're not going to balloon. Here in Louisiana specifically, you've got to have a sense that you're not going to do what you said you were going to do, and then years or decades later be sued for that. It's all about the issue of stability. And so I think it's incredibly important that for us here in Louisiana and in the nation, that we understand that when it comes to health care, which as Dr. Udvarhai said is the number 2 largest cost for business, that these costs are going to be reasonable and that they are going to be stable. And if we are able to do this here in Greater New Orleans and Louisiana, we are going to thrive as an economy. And then we're going to provide a model, quite frankly, for the entire nation on how to manage these costs. And so as we go through our breakout sessions today, I ask you all to engage very critically. This is not just an academic issue, it's an issue that is going to hit us in the pocketbook as Louisianians. Because the model of being number 1 or 2 for hospitality, best, but number 1 or 2 for healthcare, worst, is not one that's going to lead to long-term sustained prosperity and wealth generation for all of our citizens. So we've got a great base, but we do have work to do. The most important thing is stability. Folks want to know that costs are going to be reasonable and that they're going to be stable over time. So addressing all of the issues, the fact that we have overcapacity in some of our hospitals, the fact that we have a third-party payer system, so we're paying for volume instead of outcomes, the fact that we're not doing enough preventative care, all these things together have to be addressed so that we actually keep our healthcare costs down and move from being one of the most expensive places in the nation to have healthcare to somewhere that's more moderate.
Our breakout session topic was business compliance with the healthcare law. Over 50,000 pages of new regulations have been issued over the last 5 years because of the healthcare law targeted right at business. So we wanted to have a session specifically to help them make sure they're in compliance.
Our breakout session today is about how value-based care impacts employers. We are moving quickly from paying for volume to paying for value. You hear terms such as patient-centered medical homes, value-based programs. Our session is going to deal with what they are, how they work, and more importantly, why they're a good thing for patients, employers, and health plans.
The topic of our breakout today was the rising cost of prescription drugs and what we can do about that in an insured benefit plan.
What kind of an impact does that have for employers?
Well, it's a significant impact. Now 25 cents of every dollar is spent on prescription drugs, and if you don't put some basic tools and techniques in place to control those costs, it can be much higher for some employer groups.
So the topic of our seminar today was Your Health at Work and how to implement a successful worksite wellness program with your own employees. So it's important because employers have certainly a responsibility to ensure their work sites promote a culture of health. More productive employees lead to more healthy employees, and that responsibility creates an opportunity for employers to have a more productive work site. So in the long run, it's going to hopefully reduce healthcare claims costs and keep people more healthy and productive at work.
Our workshop today is on employer wellness success story. So we've obviously seen employees getting engaged both on the health aspect, physical aspect, and also on the eating and diet aspect. So we've seen improvements in all of our biometric screening results. We've seen improvement in our medical and pharmacy claim spend. And then obviously it becomes a great recruiting and retention tool for the company.
Our seminar today was about turning 65 and still working in the marketplace. Basically what we're talking about is the ramifications of either signing up for Part A or Part B of Medicare, kind of the Medicare laws, the A, B, C, and Ds of Medicare, and what they have to choose from. It's important for employees to know that if they don't sign up for Medicare Part A or Part B at the right time, there's a penalty that they could have for the rest of their life. So that's the main thing that we want them to realize.
Now we've come to our final moments in our presentation, and we are going to have a panel discussion with some real experts in the healthcare field. We're very blessed to have this group together in one place. I'm going to give each of them an opportunity to do a short introduction, and then Dr. Gee is going to talk to us about what's going on in Medicaid, which is just so impressive and moving forward so beautifully.
Thank you so much. I'm delighted to be here with one of my favorite people. I'm always glad when we bring new energy to the state, and Steve Udverhey is a phenomenal leader for Blue Cross Blue Shield, and we have already worked together on several projects. I'm looking forward to working on even more. It's very nice to be in a state where we have such a close relationship between Medicaid and our private insurance market. We can move the needle much more quickly when we can work together. Good afternoon, everybody, and hope you've enjoyed the morning. I know you've had a lot of interesting discussions. I'm going to be talking for the next several minutes a little bit about my story and my approach, but mostly about Medicaid and where we are. I had the pleasure of talking, yesterday I was at the Centers for Disease Control and spent the morning with Tom Frieden, who heads up that agency, and talked with several people about public health and talked to some of the public health leaders in Georgia. And one of the things that I think we are very fortunate to have is great leadership in our governor, is that many states that are red states have had a great challenge expanding Medicaid. If you look at the state of Georgia, Republican state, Republican governor, second term, there's a lot of antagonism to thinking about how we expand health care that's related, frankly, more to the politics of Obamacare and the very partisan, nasty politics between Republicans and Democrats in this country than the real policy debate about what does it mean to cover individuals, and should we do it or not, and what is the economic argument about that. And I think one of the nice things, and I was asked yesterday, what's the most surprising thing? Well, one of the most surprising things that has happened since taking this job was that Medicaid expansion really was not a heavy lift in a political way. One of the things we did do was we did not make the legislators have an active vote on Medicaid expansion. We realized that one of the things is divisive is just the word Obamacare. That many people have emotions related to that. So if you ask legislators to actively vote on Obamacare, in a state like Louisiana, that would have been a failing proposition. But what we did was we built the case for what it means to have coverage for individuals, and we built the budgetary case for that. And what have we done in terms of a budget standpoint? So just this year alone, we have saved $184 million in state general fund. That's $184 million that would have either had to be cut in programs, services cut, or increased taxes by that level. It will probably be more than that, frankly, but that is an enormous sum of money for a state that is poor and a state that has had, when we came into these jobs, a $3 billion budget deficit. We also are bringing in $1.8 billion new dollars into the healthcare sector. So that's dollars going to hospitals, to doctors, to support services, to support the ancillary staff and allied health, to support the goods and services that are needed to support individuals who are giving these services to people. So it's a great boon for our economy. Nationally, we know enough. We're the 31st state to expand Medicaid. So nationally, we know what happens when you expand Medicaid. And what we've seen in the 30 other states is a trend towards leveling off of healthcare expenditures. One of the things we know is that when folks don't have access to primary care, they still use healthcare services, right? And where do they use them? Emergency care, emergency rooms. One of the battles I'm fighting right now at the state level is we have groups that want to build emergency rooms on every corner of the state. And that's wrong for so many reasons, but it's wrong mostly because it's the wrong direction. We're fourth highest in the nation in terms of number of ER beds per person, per capita, so you can't convince me that it's a lack of ER beds that is the big problem in this state right now, but that's a separate note. But that's what we don't want, right? We don't want everyone to go to an ER and use an ER as primary care. That was the option they had, right? And as a practicing obstetrician, and I continue to see patients, I saw patients in my office last Friday. It's been a great joy for me to see individuals, and I've taken care now of women. As a gynecologist, I only see women for the last 7 years, and I've only had a few non-women in my practice. But I can see now that these individuals have access to care. The same people that I used to see. One woman last week who's a musician who frankly could not afford a mammogram, would put off health care, now is covered by Medicaid, full product, can get the services she needs, and that's made a great difference in her life. So the perspective that I bring to this role is one of that it's multifaceted. Obviously, I'm a practicing physician, so I bring the medical perspective. I've also been a patient. I was in a severe accident with my late husband. He was killed, and I spent 2 months in a wheelchair. So I understand what it's like to need home health services. I understand what it's like to be in a hospital for several weeks. So I've been on the side of the patient, and then I've been on the policy side. I have a background in health policy research. I know how to crunch data. I know how to look at data, and I let data drive the decisions that I make. So I bring all of those perspectives to this role as secretary, which is frankly the best job I've ever had. It is such a compelling time in this state. I look at this as a renaissance for our state. There is going to be no period in our lifetimes. Certainly 1965 was an important time. What happened in 1965? Yes, Medicare and Medicaid were passed, right? And that was a fundamental and transformative change in the American healthcare system. And then the Affordable Care Act was really, it took many, many years, and many presidents, Republican and Democrat, tried to get health reform, and it wasn't until 2010 with the Affordable Care Act that we had another chance to fundamentally redesign healthcare. And I think, unfortunately, the Affordable Care Act has been lumped into one thing. It's really many things. It's the exchange market, which has been really challenging, and I think Dr. Uverhaj could talk about that. That's, from the standpoint of the insurance industry, we've seen premiums go up, we've seen major challenges, partially due to the fact that, frankly, people were sicker than was initially thought in that population. We've also seen Medicaid expansion, which is been very successful in states. It's been successful at stabilizing state economies. It's been successful at enrolling individuals, and I'll give you a few numbers from our state. It's been very successful here. And then there were a whole panoply of things that were aimed at value-based healthcare, and which is really where I think the problem is in this country, is the fact that we don't get the value for our healthcare dollar. So some of them have worked and some of them have not. But as I talked to people throughout the state, and there was great concern about, well, how can Louisiana afford to enroll these people? How can we afford to do this? Well, my answer to that is, how could we afford not to? For a state like ours, where we were getting 62 cents on the dollar, and now we're getting this year average of 97 cents on a dollar, to fundamentally change how people get care, which is in a primary care office rather than in an emergency room, we couldn't afford not to. That's not the problem with health care. It's not, can we afford to cover people? This is the wealthiest nation on earth. To have a basic level of health care, basic access to healthcare, to me, is an issue of social justice and just common plain humanity. It's not the problem with healthcare spending. There are many problems with healthcare spending. I think we'll be talking about them today. One main one, and I'm going to be hopefully working with the National Academy of Medicine on an affordable drug study, but I'll tell you that affordable drugs is a huge challenge in our nation. If I were to cover, for example, everyone just on Medicaid who has hepatitis C at the discount price, guess how much it would cost me just for Medicaid? $2.5 billion just for Medicaid. And so I've put together an advocacy of, well, what if I were to do that? What are the two big buckets in our state budget that are modifiable? And this is a structural issue with our budget that frankly should change. It's healthcare and it's education. So what happens when healthcare costs go up? What happens to education? Down, right? So we make trade-offs. We make very big trade-offs when our healthcare budget goes up. And so pharmacy spending, huge area of concern. Doing things. There's something called Romer's Law. A bed built is a bed filled. We are way, way too focused on giving services to people, putting them in beds, doing interventions. Because why? Because we are still largely fee-for-service based. We are not a healthcare system, we're a sick care system. Physicians, doctors get paid, hospitals get paid to do things, not to make people healthier. So I really think a challenge in our nation, and one that other developed nations have tackled much more successfully that have lower costs, is to think about how do you provide a holistic array of services that actually leads to better health. So for example, what if instead of paying a rural hospital their cost plus to fill their beds, we paid a rural hospital their cost plus to make everyone in their neighborhood healthy? And what if instead of having Mrs. Jones come in 5 times into an emergency room in August because she's dehydrated, we actually buy her an air conditioner and get someone to go to her home and assess the quality of her living conditions and whether she needs home assistance. Those are the types of things that would save money, but it's not the way we structure healthcare payment. And to fundamentally make people healthier, we have to think about their social environment. We have to think about the determinants of health that are outside of a clinical office setting, and how do we support those, and how do we reimagine healthcare payment? And I think that is the big challenge. That is where we are not getting the value. We are spending almost double the next lowest state on the globe for healthcare, and getting some of the lowest life expectancies, greatest obesity, greatest hypertension, greatest complications from chronic disease. And so we are largely unsuccessful with our healthcare spend. How would you define value? I would define value as getting a lot for your dollar, right? So the U.S. system, my view is the biggest challenge is it's not giving us the value that we need. And so that's our fundamental challenge. And as I see it in this role, my fundamental challenge is not to just expand Medicaid, not to just give people a card, but I'll give you some numbers before I finish that are very exciting to me. But it's to fundamentally shift our system towards a value-driven system, into one in which people are healthier. I will have failed at this role if at the end of my time here, people of this state are not healthiher for the fact that we expanded Medicaid. So we have a lot of work to do, and I look forward to working with members of the business community, with Blue Cross Blue Shield, and with other providers to make sure that we are a healthy Louisiana. So one of the big, and I'll finish with the thing that I'm most proud of and that's happened in the last few months, is the fact that we realized that we were going to have to do Medicaid expansion without any additional dollars or any additional staff. We had a $3 billion budget deficit. We have a culture where state employees, I think wrongly so in most cases, are viewed as a drain on our system. You know, I have a department that has a $12 billion budget. When Jindal started, we had 12,000 employees. I now have just a little over 5,000 people running our department. And sometimes more is more. I mean, less is more, and sometimes less is less. There are certain things where I am sure there is money going out the door just because we need more people overseeing certain programs. And wherever we find that, we're going to continue to fight to structure the work that we do in a way that is most responsible, because you actually do have to have people to run programs. You actually have to have people in public health units, if there's a full coastal evacuation, to take care of the medical needs of individuals. So there is a trade-off between efficiency and making sure that we have a sustainable model where public health is supported. So we were able to do it, though. In this case, I think the good news was that we didn't actually need more people or dollars. So without more people or dollars, we had to think about how could we do Medicaid expansion in the most creative way in the nation. So we looked at those ideas that were out there that other states had tweaked or tried, but no one had done as a full-scale model. We were the first state then nationally to use the food stamps program to enroll individuals. So that's great because we already had an employee who was doing food stamps enrollment. That same employee now can do Medicaid and food stamps. The individual going to sign up for those services doesn't have to take 2 days off of work, go to 2 different offices. We don't have to pay 2 different rents for 2 different spaces. It's streamlined. It's one process. We were the first state in the nation to do that, have almost 100,000 people enrolled due to that process, which I'm very proud of. Second thing we did, use our managed care plans to be an active participant in enrollment. The third thing we did was do outstationing. So we have, with the federal government, the ability to actually fund individuals to be in clinics, nursing homes, hospitals, pharmacies throughout the state who can sign individuals up for Medicaid at no cost to the state and at a small cost to those businesses who are sponsoring those individuals. So that was a very efficient way and in a way that was much more customer friendly. So if you go to an emergency room in many parts of the state now, you're leaving the emergency room with a plan about how you're going to get Medicaid, rather than having to leave that emergency room with a social worker telling you to go to a Medicaid office somewhere it's not convenient on a different day. So that worked great. And finally, we had a program that we had created under the digital administration that was a limited benefit Medicaid program, and we were able to flip individuals into Medicaid. So I'm proud to say we have 326,000 people in Medicaid as of today. And one of the big challenges that we have, I was up on a panel in Washington, D.C. a few weeks ago, and one of the detractors said, yeah, sure, Dr. Gee, you know, Medicaid expansion, it's a card, it's meaningless, right? Doesn't mean anything. People can't get care anywhere, who cares, right? But let me give you some numbers. This is why we should care and why having coverage matters. And I would challenge anyone who says that having health insurance or health care coverage matters to get rid of their own health insurance and tell me it's not important for them to have that level of security and service. But what are our numbers from Louisiana? So in the last few months, the new individuals who've gotten primary care are 25,000. So we've had over 25,000 primary care appointments for new individuals, newly insured, in the Medicaid program. My mom died of breast cancer, so breast cancer prevention is a big thing for me, something I care about a lot. We've had 2,000 women get mammograms, ultrasounds, life-saving procedures, and over 24 diagnosed with breast cancer and get treatment who would not have otherwise had access. We've had almost 1,000 colonoscopies. We've had 500 people diagnosed with hypertension and about half that many newly diagnosed with diabetes. That means individuals who didn't know they were sick, might have had an amputation or a complication of diabetes, now can have access to the medication management and counseling they need to be healthier. So these are real people, real numbers, thousands, tens of thousands of individuals. To get Louisiana out of 50th, to be 50th no more, we must change how we deliver health care and the health behaviors of the state. We've got to get smoking rates down, alcohol use down. We need to stop drinking sugar-sweetened beverages and think about the social environments in which those things occur and how we affect change and positive change on those behaviors. But healthcare coverage is an important piece, and I'm very proud to say that just a few months out of the gate, for a state that frankly had not done a lot of planning in the prior administration to be prepared for Medicaid expansion, I'm very, very excited for what we've accomplished and believe that, and I'm very optimistic about the fact that we can change the future for the better in this state. So thanks so much for having me today.
It's becoming increasingly obvious that drug pricing and the behavior of pharmaceutical companies has drawn some negative attention in the press lately. A recent report by the Bureau of Labor Statistics showed drug pricing increased over the last 12 months by the largest percentage since the summer of 1994. That's a long time. So what we want to think about is how these price increases threaten our attempts to integrate the system and to deliver efficient and effective health care to as broad a population as possible. And I'll let you guys have the parting shots on that question before we call it a day?
Yeah, so, the rising drug prices, I think are a problem. It's not all bad, and what I would say by that is that new drugs that provide treatments that we haven't had before are a good thing. And we'd be more than happy to pay more for a drug treatment than a lot of other things that are less effective. So, I think the example that Dr. Gee gave of the hepatitis C drugs, Sovaldi, Harvoni, et cetera, from Gilead, are a good example where if you are an appropriate candidate for those drugs, you will likely get a cure from those drugs that you would not have gotten if you had been put on older drugs like interferon, et cetera. The side effects of the new drugs are less, et cetera. So paying for those, even at a significant degree, is not bad. The unilateral ability for Gilead and other patented drug makers to price it in a manner that just is whatever they want, or the EpiPen example of just having that go up, there's a policy issue there which has a lot of political problems associated, again, for the reasons that Dr. Gee mentioned, which is that, federal policy and other things are made and influenced in a way that I think ratcheting that back is difficult. We pay more for a lot of these drugs in the United States than the same drugs are paid for in other countries, so we should understand that we are disproportionately funding for the world the R&D of drug development. Again, the new drugs are good, but we're disproportionately funding it. So I think we need to have some rational pricing. Candidly, none of us, whether you're in the state purchasing, whether you're a payer or even in the provider side, none of us have the ability to really alter the pricing behavior of the pharmaceutical industry where there is not choice. Where there is choice, and a good example is in sort of the non-specialty drugs. So in antibiotics, where there's a brand antibiotic and a generic antibiotic, the generic antibiotics, which are historically cheaper, that provides an alternative, and you can have drug prices come down. Or even in a therapeutic class, if there's several different drugs that essentially do the same thing, they may work a little differently, but at the end of the day, they all really have the same outcome in a therapeutic class, you can have price competition there. When you have one drug, particularly these specialty drugs, in an era of personalized medicine, it's very hard to have some kind of force that brings those costs down. And I think we probably are headed, even though it's unpalatable, I know, in an American economy to have some discussion about regulation around that. We're probably headed that way because of the exploding costs. A bigger issue, I would just say, is it's not just pricing. We, as a country, use drugs inappropriately a tremendous amount of the time. And, a good example is antibiotics for upper respiratory tract infections. There's a twofold problem there. 70% of the prescriptions handed out aren't needed. And if you ask physicians, why do they do that? And this gets to sort of the issue that you have is, it takes longer for a physician to explain to a patient who's coming in with an expectation to get a prescription why they don't need it, and it's less satisfying for that patient because they didn't get what they wanted than it is to just write the script. So a lot of docs just default to writing the script because it's a 5-minute exercise instead of a 20-minute exercise. But when they do write the script, they're also writing for higher priced brand name antibiotics rather than some more appropriate generic ones. So I think that while the national news media has focused on the pricing of the high-cost drugs, and there's no question that some of that's escalating initially, we have a huge problem of overuse of medications. And
over prescribing, and actually Dr. Gee and I are talking about, just some of this. If you look at sort of the number of pills dispensed with First Scripts, and opioids is a good example, we give out too many. They sit in the medicine cabinet unused and unspent, and in some cases cause hazards associated with it. So I think we need to tackle those parts of it that we can, overuse, inappropriate use, et cetera, begin to make headway there, and hope that on the actual pricing itself, we'll get some, hopefully regulatory relief on that. I don't know if
So
That was very politically correct. The biggest, look, misuse of medications is real. He's right. We've measured it with our doctors. We know that's real. At the end of the day, it's a drop in the bucket compared to the total medical spend of pharmacy drugs. Half or more of the new drugs in development in the pipeline by pharma are specialty drugs, which have price tags in the thousands of dollars. They treat rare and common conditions. Medicare, the federal government's the largest purchaser of pharmaceuticals in the United States, and the pharma industry is the only sector of the healthcare economy that doesn't have a fee schedule. And really, at the end of the day, this is, and again, I've avoided politicizing healthcare because I don't usually think that good solutions to complex problems like healthcare come from politics, but at the end of the day, the pharma lobby spends more by far than any other lobby in Congress and has exempted the pharmaceutical companies from a fee schedule. Every one of us in healthcare, whether you're a device manufacturer or provider or hospital, has their fees set by Medicare, and I think that that's going to have to happen. Now, I think the pharma industry will say that drug development costs have gone up, and to the degree that you don't allow us to recoup our investment, drug discovery is going to go down, and people are going to suffer. And I just think that that's great as a soundbite. I think there's some more sophisticated ways to look at how patent laws are written and patent protection exists. So there's a finite period of time after a drug comes to market that a company has patent protection where another manufacturer can't make the same drug. Well, why couldn't you attach perpetual royalties to new molecules that are designed by companies? Shorten the patent protection time, actually allow competitors to compete to make the molecule at a cheaper rate quicker to drive competition and price down, but allow the company that discovered the molecule to actually earn royalties on each one of those that are sold forever, as just a way to kind of change the financing mechanism. So I think there are solutions for our pharmaceutical challenge in the United States, but I think it's going to take both a change in patent law and a significant change in payer policy at the CMS level.
Well, we could also get rid of the advertising. The United States is the only country that allows pharma.
And then your kids can sit and watch a football game with you, right?
Right. I mean, seriously, right? So if we didn't have all that advertising, you wouldn't have people walking into their doctor's office sitting, giving me the latest and greatest, which creates, going back to that problem, which just creates the expectation, which the doctor's so frustrated about because they can't talk the person out of what they saw during the Super Bowl ad. So.
Excellent. Dr. Gee, would you like the last word on this?
Last week I published a paper in Journal of the American Medical Association called Pharmaceuticals and Public Health, where I made an argument along with the former Commissioner of Health for Maryland that there are certain drugs for which there is a public health benefit and that we have to have a different pricing mechanism for those drugs, number one. I think that there are certain things, whether it's think about a communicable disease, the Ebola epidemic, you name it, there are certain things, if we had a severe flu pandemic in the United States, there are certain things where we need greater production, we need generics, affordable pricing, number one. Number two is that we don't have competition and transparency in the market. There is no negotiation, which needs to change. You can't have a program. Medicare Part D was a great, bless you, great idea, but terrible that we don't negotiate prices, because the bottom line is that the taxpayer funds these companies to a great degree and in a way that is not transparent. I sat on the Pharmacy and Therapeutics Committee for Medicaid for the past 3 years, and Senator Mills and I would pull out our hair because we would be asked to make decisions on drugs to be covered by the taxpayers of this state for the Medicaid population and decide which ones were preferred. And do you know what information we were given on pricing by law? Because this is how, some of this is not transparent. We would see dollar signs. It would either be 50, 35, 20, 10, 5. And we'd say, well, what does that mean? And they'd say, well, we don't know. We can't tell you. We're not allowed to tell you. So here's a whole state economy, billions of dollars potentially could go out the door by making decisions about drugs, and the people voting on the preferred drugs don't even know the price. So that is a problem. We need transparency. We need accountability. I also think we need to change. There's been a lot. If you listen to National Public Radio, and there have been a couple of really recent reports on placebo. Some drugs, we only have to compare drug to drug. We don't have to compare drug to placebo or nothing. We have to also be more vigilant, I think, about publishing negative studies about what doesn't work and making sure that we show that there's an actual value and what that value is and monetizing it. Number 3. And then last I'll finish with, I think that we do have a crisis in this country, and there are areas where we are not treating, and I think cancer is the most egregious. Is if you have cancer, what are you going to say if you need an oncology drug or a chemotherapy drug and it's priced a certain way? Well, it's either die or get this drug, or your two choices. So we put cancer patients, they're hostage. It's not like Botox. I mean, Botox is a thing I actually think should cost whatever, unless you need it for health reasons. If it's expensive, great, decide whether you want it or not. But you have cancer, you ought to be able to get a drug, particularly if there's public funding going into it that's affordable. And we have a couple areas in this state that are bugaboos for me. One is hepatitis C, and I mentioned it earlier. It would cost me $2.5 billion to treat everyone just in Medicaid with hepatitis C at their discount price. That's just plain wrong, because that's leading to either me having the state having a budget crisis or lack of ability to treat, and we need a middle ground. We've been working with Gilead on some possible solutions, but it's not moving nearly fast enough. And the other area is prematurity. Prematurity is a disproportionate number of African American women have premature babies, and who are pregnant are low income. They are not paying for the drug. There's one drug that has an intervention that's very important in pregnancy. This is a publicly funded drug. It's largely the Medicaid program that funds this drug, and they want to price what we know is about a $15 drug at about $700 a pop. And so the choice I have now as a policymaker is either and there's no competition. So either women don't get treatment, or I pay this and it affects the state budget. So they're really structural, budgetary, and legal issues that need to be addressed in this country. We need fairness, we need excellence in research. We've got to promote that. We are the research capital of this world in terms of science and medicine. That is laudable. But we can't do it at the expense of the American taxpayer and limiting choices for things that are really life-saving for hundreds of thousands of people in this country because of pricing. Drugs in the United States are some of the highest prices in the world. We do the best job in this nation of developing new drugs, of being the innovators, but we also do some of the worst job in the world of actually making sure that drugs are affordable for people. So our challenge is to think about how do we make sure that companies succeed and thrive, but also make sure that the public can get drugs that are life-saving. And so that's a delicate balance, and we're at a real crossroads in this nation. I just wrote a piece in JAMA about some of the areas in public health and some of the solutions where I think we could actually come up with a better way to fix the problem.
The business community's response to these issues has been tremendous. They get it. They understand what the issues are, and they're looking for partners that can help solve this for their employees. Because candidly, if employees are preoccupied with their health care or the health care of their family, they're not paying attention to the job that they got hired to do. So employers understand it's not just a cost issue, it's a productivity issue, and they do not want to stand by passively and honestly wait for the government to try to solve this, and I think we've seen where that's taken us so far. So they want to get engaged with us as a payer community and with the providers, and I think the discussions we've had here today really help them get engaged on practical solutions.
We've made tremendous progress in the first few months of this administration. We have 326,000 people enrolled in Medicaid, 25,000 getting primary care, over 2,000 women getting mammograms, preventive services, 1,000 colonoscopies, 500 hypertensive, 250 diabetics, but we are not done. We have a lot more to do to ensure that the people of Louisiana are healthier. And to do that requires systems changes, it requires policy changes, and it requires partnerships between Blue Cross Blue Shield and Medicaid. We're very committed to doing.
Today was really a great opportunity for us to engage with the New Orleans business community. Gave us a chance in the breakout sessions to have informal discussions, which I think were very lively, well received. and got people engaged on issues of importance to them. And then the panel discussion was a great way to wrap this up. It was a way to sort of frame a summary of the issues, but more importantly, talk about a pathway to resolving these as we move forward.
Blue Cross is the expert here, so we need to have organizations like Blue Cross leading the conversation so the business community can listen, learn, and then take action. They're the domain experts. We can take action. So together, it should be a potent force for change.
If people want to get more engaged on these issues, I would encourage them to check the Blue Cross Blue Shield website. We have a lot of information there. We have a blog from our health economist, and really a wide range of resources to help them get engaged on these issues with us.